Is being recorded and will be shared with all the registered participants. All attendees are muted by default to prevent, minimize, and background noise. Please use Q&A box at the bottom of your screen to submit questions at any time. We will address them during the Q&A segment towards the end of the webinar. If you experience any technical issues, please message our support team via the chat box. Moving ahead, today's discussion on transforming patient outcomes in India, the power of healthcare technology, holds an immense relevance as patient safety continues to be a critical global health priority. We will explore how technology can be a powerful enabler in improving patient safety, standardizing care, and achieving better outcomes. With that context, I am delighted to introduce our eminent speakers who bring such experience and perspective to today's dialogue. We have Dr. Girdhar Jigyani, Director General, Association of Healthcare Providers, India. Dr. Sanjeev Singh, Medical Director, Amrita Institute of Medical Sciences. Sir will be joining in a while. Dr. Atul Mohan Kochar, CEO of NABH, and Dr. Jennifer Benjamin, Clinical Effectiveness Expert at Wolters Kluwer. With that, let's begin our wonderful session. It's my pleasure to invite Dr. Girdhar Gyani, a pioneer in healthcare quality and a leading voice in patient safety policy in India. Dr. Gyani will share his insights on why patient safety must be a national priority and how technology can play a transformative role in Indian healthcare. Dr. Gyani, over to you.
Okay. Thank you very much, Muskan. And good afternoon to my fellow panelists. Dr. Kochar is here, Lakshya is here, and Sanjeev Singh will be joining very shortly. Now, this topic, transforming patient outcome in India. And actually, that is a general topic, but specifically, we want to focus on how the healthcare technology has impacted the patient safety in our country. So let me begin with by saying that our average life of expectancy at the time of independence was around 34 years. And today it has gone to 73 years. Now, what are the factors that this life expectancy has increased manifold? I think we have to understand one thing, that technology definitely has played a key role, whether it is a pathology or whether it is a radiology. I think the kind of diagnosis which we have to improve has a lot of impact in improving the average life expectancy. Second, I will say, is the medical education. The kind of expertise and specialization which we have been adding year after year. And today, I think our doctors, not only in India, I think globally, they are recognized for their expertise. So I think the credit goes also to our doctors who have been able to, get on to this subject of patient safety. And the third factor, I will say, the coming in front of the NABH on the market. The 2006, when we launched, now it is almost 20 years, I think NABH has made I will say, huge impact in improving the patient safety. The simple point to understand is that though we have our doctors, specialists, they do try to follow the standard treatment guidelines to best of their understanding. But unless you have the framework, unless you have the governance model, unless you have the system in place, we will not be able to achieve the cohesiveness or the synergy between the efforts of the doctor, nurses, paramedics, management, and things like that. I think that is a simple job which has been done by the NABH. Today, I think Kochar, of course, will tell us a little more. 20,000 plus hospital nursing homes have some kind of accreditation. Rather, they have the accreditation, and remaining they have got certification, and some of them are impaneled. But all these 20,000 plus, definitely they follow not only the system, but the governance model. And over and above, they share the clinical outcomes, which is the real thing, which actually demonstrate where we are in our country in respect of patient safety. And they share it with the NABH. So I think this journey, which has taken place in past 20 years is, I will say, give credit to this journey and our, this assessor and the staff at the NABH, and overall the participation by the hospitals. And one more point I would like to add here is that ideally regulation should have made impact on the patient safety. But unfortunately, the Clinical Establishment Act is hardly implemented in about 13 states. That too, I will use the word here, on paper. So in absence of regulation, I think it is the accreditation or certification which has taken role on itself to be, I will say, a kind of regulatory. I don't want to use the word regulatory for them, but because many of the schemes like CGHS and now even Ayushman Bharat indirectly links with the certification of NABH. And in fact, I was talking to General Insurance Council on 9th October, and I made a very strong plea that this 30,000 nursing home or clinics which are on their panel, they should bring back this element of mandatory certification before they are impaneled. I think we are going to work on that. So in all, these are the three factors, as I mentioned: technology, expertise of our clinicians, and the systems by the NABH, which have really taken the patient safety journey in our country to really a next level. But still, of course, we have a long way to go. So I think we have got three panelists, I will call them, to share their experience. And because in the serial number, of course, Sanjeev is mentioned first, though you have come a little late, but still, I think I will invite Sanjeev Singh. I will tell you that there are three things which I want to ask you, but I don't want to ask you as a questions. The one thing is, what are the top three patient safety challenges in your own experience which hospitals are facing? That is the point number one. Point number two is, which is the single biggest barrier to technology adoption in Indian hospitals? And third is, what role should leadership play in driving the culture of safety supported by digital tools? I think all three are interlinked, if I can say so. So I will give you around 10 to 12 minutes to spell out the answering these three questions which I put up for. Dr. Sanjeev.
Right, sir. Thank you so much. Very, very good to see you. Very good to see you, Dr. Atul. Good afternoon. And thank you, VOH, for this opportunity. I would like to start on a on a slightly personal note. My wife, who's a professor of anesthesia and palliative medicine, had spondylolisthesis, and she had S1, S2 fracture because of her post-ERCP pancreatitis and a lot of other unfortunate issues. And she had two disc prolapse. So she was slated for a surgery, which would be laminectomy along with an internal fixation from L2 to S2. So she was there in the theater, and she was getting prepared. She got induced. They were putting a central line. In this particular hospital, the sonography machine was there, but the anesthetist thought that he's pretty senior and has done it multiple times, maybe 1 lakh times. So he went blind, introduced a subclavian, and unfortunately perforated a subclavian artery. Didn't realize at that point of time, and withdrew, though the sort of this thing was pulsatile. And the blood pressure dropped from 60 to 40 on the operation theater table. Nobody had a clue what went wrong, because unfortunately the person who was introduced also didn't indicate that the stilette was pulsatile, because an artery recognized, but somehow he didn't. And for 3 hours, it happened like that. They did an echo. Fortunately, they realized that there is a cardiac tamponade. There's a huge collection of blood near the heart. So from a sterile environment, that is operation theater, sterile practices, she was shifted to another sterile environment, which is cath lab. And then her blood was drained. And within 48 hours, she grew Acinetobacter. So from a sterile environment, sterile practice, but there was a breach which could easily be preventable. And she was there. She couldn't get a spinal surgery done, but just to manage the heart, she was there for 2 weeks, 6.8 lakhs of bill. So what I'm trying to say, the sir had asked the three major issues. Healthcare associated infections is a major issue. And that, unfortunately, we are in a low middle income countries, we are grappling with it, and we know there are breach in protocols, we know that there are unsafe practices, we know that this is definitely hospital acquired or healthcare associated. You and I are responsible, but it happens left, right, and center. Though I would also say that there are 10 chapters in an NABH, and one of the most chapters where attention has been given is chapter 5, which is infection prevention and control. But long way to go. So one of our area of attention or urgency is healthcare associated infections and antimicrobial resistance. So that's definitely one. Second is, despite everything, medication errors and medication management still remains a area of debate, and which again requires huge attention, because it could be prescription errors. We know how legible doctors' handwritings are, and the doctors, senior consultants may not write, and the junior consultant write, and then that is transcribed by the nurse on the drug chart. So there are transcription errors. We don't know, every drug has a different dilution mechanism, so there are dilution errors, because if it is to be diluted in normal saline and you do it in 5% dextrose, you do an error. There could be administration errors, there could be dosing errors. So there are errors which are happening, and that also requires a good bit of training, both from the faculty as well as from staff. And there is a group which is called as clinical pharmacists, who are very well trained. Unfortunately, we generally don't sort of employ because of the budget factor. But then they, like we sort of costed medication error. So one medication error in our hospital was 36,000 rupees. And if you employ a clinical pharmacist, if he takes care of two, his salary is all sort of taken care. So medication error is one, medication management. And third is culture. Unfortunately, despite sir mentioned about 20,000 hospitals which are accredited and certified, we are still unable to establish a culture of patient safety across the institutions. So the clinicians, they are still, despite everything, are group of people in hierarchy which are above God, and we are unable to sort of talk to them. And they non-participation, non-engagement is also okay. The nursing staff for the next 1 decade will not be available in India. They will study, they will do 2 to 3 years of work, and they'll go abroad. And it's not bad, but unfortunately, the replacement of a senior nurses who go abroad is always a junior nurse. And then again, the rigmarole of training starts. And even if they report, the hospital should have a non-punitive, non-blame free, because the immediate reaction is to just kill the messenger. Because and everybody uses the word RC and kappa, and RCS kappa is only to kill the messenger. And that is the culture which we are unable to establish, so that you can freely create speaking up opportunity and then work on it. So that's, I think, my three things which requires attention: healthcare associated infection and antimicrobial resistance, medication management, and the culture of patient safety. To the second question, what best can be done to create that kind of a patient safety environment, and what the leadership will play a role? I think leadership role is paramount, because they themselves should, other than the finance, which is important, other than the return of investment, which is important, other than the cash flows and the balancing of the budget, which is important, it is also important that the outcome of the patient is benchmarked according to the international and the national scenarios. So it cannot be that we don't subscribe to that feeling. So leadership and clinicians' engagement again would be very, very important to be able to create that kind of an environment where patient safety is very, very critical for as an agenda for everybody. Now, the other thing is that we keep talking about benchmark, but then there is no data. The data is again in silos, few islands of excellence, has some bit of information, but then there are 80,000 hospitals across the country. It cannot be just good 50 hospitals. So that you never know how good you are, because that the national database or even the state database or the district database also doesn't exist. The again important is that when you put in any bit of tool, there is a cost to it. So you will always have to balance between the benefit and the harm when you put in a digital tool which will be important for the patient safety and which has an impact. So that would be again from the leadership side, it would be important. And a good phenomena would be health technology assessment as a decision making, where you look at cost, you look at science, and you could look at ethics. Now, what should we do to be able to drive this phenomena? I think the leadership should definitely have the strategic mission, vision, values very, very clear. Everybody, though, talks about providing best possible affordable care, uh, but then that with high quality and ethics, but then that has to translate into zero harm. Because if we are agreeing that we would create a culture and a capacity and the training and an environment where it would become an enabler rather than become a punitive thing, which would be again very, I think, disruptive to the whole environment. There are many, many tools now which are available because the data exist and they can easily predict. We have tried this in antimicrobial resistance because fever is one criteria where antibiotic gets given because it's considered as a magic bullet. Because if it is fever, we don't look at inflammation, we think it's infection and we would like to give antibiotic and then don't stop. Now we are seeing that through our school of AI, which we have within this healthcare campus, that many times this data with the biochemical parameters and microbiology parameters, this prediction is incorrect of giving an antibiotic just in case of fever. So there is a good predictive analysis, and such tools should be adopted because then you are more rational in your practices and you don't always give broad spectrum and beat around the bush. Whatever tool, what also, there are lots of apps, lots of things which we have developed in our previous hospitals in Kochi, in Faridabad. But unless the engagement from the senior resident, the junior resident, and the faculty is there, you can have fantastic technology. It is of no use. So I think the user centric, user friendly, and engaged development of the digitalization, which is good for adoption, is what we should develop. Otherwise, it's a good tool to have, but it would be completely waste of energy and time and money. So that's it from my side, sir.
Thank you. I think you have summed up very, very nicely for me to go to the next panelist, and Dr. Atul Mohan Kochar. So let me say, Dr. Atul, today, if I want to use the word patient safety, it is synonymous with NABH. I think there's nothing more to describe the value of the NABH. But the important question which we want to discuss today, one, of course, the people would like to know from you, what is the role of Quality Council of India and, of course, NABH in promoting quality in general in healthcare? That is one. But more importantly, you also are promoting, you also have the standard on the technology now. And this is quite few years now that this standard is in operation. I would like to know from you, and so is my panelist, and so is the audience, that how you have been able to be successful in bringing technology, or rather driving the patient safety with the use of technology through the basic NABH standard and through your supplement standard on the technology. I think these two things, if you can really elaborate in next 10, 12 minutes, I'll be, I will insist, or rather I will expect that to be covered. Over to Dr. Kochar.
Oh, thank you so much, sir. I'm so grateful to all of you, to VOH, and all the panelists for this opportunity. It's such a great privilege being in the same frame as yourself, Dr. Sanjeev, and all the other panelists. It's a great opportunity, and sincere great gratitude for that. So this is a great topic, and thank you for raising all the right issues. So QCI, many of you, I mean, probably all of us are aware that Dr. Gyani sir is the quality man of India. He's the founder of NABH. He triggered that movement. And on 27th June, we just completed, just gone by, we completed 2 decades. So it's a very, as cultures go, it's a very nascent culture. I mean, you average is about 25 years for a culture to change, right? And this is the culture of patient safety where the world is battling the same issues. Like as doctors, we take an oath of primum non nocere, first do no harm. But unintended harm is still the top 10 causes of mortality and morbidity, as Dr. Sanjeev rightly pointed out. And there have been organizations like JCI 72 years, ACHS 52 years. I mean, they have much seniority in age and probably experience, and probably they're being developed in smaller nations. But they themselves, despite the concept of universal health, today have not been able to touch the length and breadth of their whatever size countries they have. And India is a big country. India is a diverse country. We follow a federal structure. We are, I always say, we are not one country, but we are probably 36 country, 28 states and 8 union territories rolled into one, each with a population big enough to be counted as a small to mid-sized country in their own. And health being on the concurrent list, there have been challenges. Some states do very well, some not so. But the idea here is, as Dr. Gyani sir also rightly pointed out, that with the longevity increasing, with the challenges increasing, the growth, which are like we are soon to be a 5 trillion economy, and we are on the path of Viksit Bharat. But somehow the intent and the extent of patient safety and health care quality is still in a very formative and nascent state. So technology, sir, you very rightly pointed out. First, a little bit about QCI. NABH is one of the boards under QCI. QCI is headed by a chairperson. The first chairperson was Shri Ratan Tata ji, and the chairperson of QCI has always been appointed by Honorable Prime Minister. It itself is a very young body. It came about in 96. And Dr. Gyani sir was one of the Secretary Generals of Quality Council of India. So though he is also the first CEO and first founder of NABH, but he had a much bigger role to play in the Indian quality movement, because QCI has a mandate of or a vision of creating a ecosystem of quality. So that's a fantastic vision. Wherever there's a need for standards which are to be felt, like government fields, industry fields, they approach QCI. And today we feel very proud and privileged that we partner with more than 56 ministries. Not only that, a whole lot of industries, because FICCI, CII and ASSOCHAM, they have been the founding members of QCI. And today we have a huge spectrum of activities ranging from quality of coal to Swachh Sarvekshan to the entire drone policy to doing the all gem vendor assessment, government e-marketplace, to doing the assessment for production of all the military production under DRDO, which happens. So these are just small 3-4 areas, but there are about 200 projects which QCI is very proud to undertake in the back end, and very few in the front end also. And many of these are highly confidential. We work very closely with PMO. We work very closely with a whole lot of other bodies, national and international, to give shape to the entire standardization and quality structure of the country. So Healthcare Board, as Dr. Gyani founded in 2005, it was founded 27th June to be exact. That's the date we take it. And next year in 2006, the first standard, as we know it, the hospital accreditation standard, the flagship standard, was released. And since then, today we are operating about 29 schemes or programs, the latest being the digital health program, the HIS and EMR product program, and also now we have clinic management software, besides a whole lot of other programs. All of these programs or standards, so we call it, are free for download from our website, nabh.co, www.nabh.co. So any of the viewers who are keen to download, there are no charges for that. They can simply download and start being compliant. There are a whole lot of resources, templates, policies, video evidences. So everything is there in the form of e-Mitra, Q-Mitra, chatbot. We have a toll-free line, etc., and a very well furnished resource page, so that any small or big hospital, should they choose to follow that, they can download and start their quality journey immediately without waiting for a third-party assistance or any help also. So these are something very, we operate under the 4 broad headings. So one is the accreditation, which are a very robust standards where we have core commitment achievement and excellence criterias under the objective elements. So we follow, as Dr. Sanjeev pointed out, he's the principal assessor with us, one of the master trainers. And so we have this 10-chapter approach, which follows the Rumba principle. Rumba principle means relevant, understandable. Hello? Yeah. So
You are audible, sir.
thank you so much. Yeah. So relevant, understandable, measurable, beneficial, and achievable. So this, whenever we draft a standard, first we see that the overall acceptance should be about 85%. That means for any healthcare facility, they should aspire to be a part of those standards. There's no point crafting standards which are too draconian probably, or too harsh for a or non-practical. So they have to be beneficial, of course, they have to be measurable, because there has to be an essence of objectivity to it, and then they have to be understandable, and of course they have to be relevant to the Indian culture. So this is again the QCI or NABH culture which Dr. Gyani sir founded, and with the help of about 3,600 assessors, of which about 2,600 are active assessors. The rest we deploy for trainings, capacities, and capacity building and skilling. So that's a huge force which NABH has created. And today we feel very proud and privileged that we are partnering with about 26,000 plus hospitals. And every month, at least 300 new hospitals are joining under one or the other program. So this 26,000 programs, hospitals, accreditation is the most robust one. Then we started a certification concept, only because we feel that one size does not fit all, and we need some sort of core standards and systems where at least the hospitals start on their quality journey. The culture C will come later. And Government of India incentivizes these programs in very tangible benefits. I mean, the non-tangible, the outcome-based benefits, of course, will flow in, but the tangible benefits of 10 to 15% upmarking against the published IRDA, TPA rates or empaneled rates from ABPMJ or CGHS, that translates into a very credible and sound financial sense also, with a very marginal input and very significant ROI in the investment for quality. Third is the empanelment program, which we are undertaking on behalf of Ministry of Health and Family Welfare and also for Ministry of Defense under the CGHS and the ECHS programs, where as of date, we have about 5,700 hospitals. So these hospitals, even though not compliant totally with the NABH standards, these hospitals also are on the path of quality and used to following the checklist or some sort of SOPs versus a hospital which is totally not a part of any empanelment system. And beside in the fourth vertical, so accreditation, certification, and empanelment are three broad verticals where we engage with the partner hospitals. Besides that, we do lots of training under a program called Gunvata Pathshala. So Gunvata Pathshala is a training, skilling, and capacity building where we have taken it upon ourselves to skill 100,000 quality people, quality champions in the current calendar year. Uh, I mean, extended till 31st December next year. So this is a big thing for us. Otherwise, till date, we have already skilled about 50,000 certificate plus certificate courses, and these are low cost, very popular courses in the form of documentation, medical audit, clinical audit, infection control. I think that also serves a very niche area. In our recent offerings, we realized that technology is the bridge which is going to bridge between the islands of excellence and the small spokes which are there. So Dr. Sanjeev very rightly pointed out that over time, if we can take it over the past 2 decades, probably we have been building islands of excellence, which are second to none, which are so that India is today probably the cradle of medical value travel, offering their services which are cutting edge, next to none, at fraction of a price, probably 1/10 of a price to what they are prevalent in the other nations. But if we are to reach to the last in the line, if we are to raise that herd quality, if we are to raise the level of quality to the next level, we shall fail in our duties unless we raise the level of the last in the line. The small tier 2, tier 3, tier 4, tier 5 hospitals which are offering, and probably today which are not as well conversant with even 7 basic patient safety goals of communication safety, hand hygiene, or others, right side right surgery. So all those things we have to take, and this is another effort which we have taken it upon ourselves. So another few projects which we undertake are, for example, we have undertaken to capacity assess and capacity build all the Anganwadis in the state of Nagaland, or all the entry-level hospital, all the smaller hospitals in remote areas in the northeast like Mizoram and Assam. So these are also, besides that, we work very closely with Ministry of Ayush, for example, and we have already assessed about 2,000 Ayush Arogya Mandirs, and they are the last in the line, the smallest kit unit of healthcare delivery in remote and very remote areas, and they do not and these numbers do not form part of our 26,000 plus hospitals. So these are separate state-wise projects which we undertake along with active participation of state machinery, like assessment and capacity building of all the homeopathic medical colleges, which are 264 in number, or engagement with all the Ayurvedic medical colleges. For example, there are 550 plus Ayurvedic medical colleges. So there are many such small and big projects which we undertake, which are mostly absolutely pro bono, and we work for the government along with the state machinery and add value to that. So I would say, sir, that the seedling which you planted, the quality movement, so NABH no doubt is a big reckoning force, and this is after all a framework. The NABH framework it has become a very credible framework because of the values which we have, like the credibility, the responsiveness, the innovation, and the transparency. All our work, all our applications, all our decisions, which are taken by an independent committee, are given out in a transparent public portals, which anyone can log in and see. So that's another value. So here there's a cause for, I'll come to the challenges in a while, but so this is what QCI has been doing, the NABH particularly has been doing under that. But still, I believe it's a long way to go, because as Sir mentioned, as Dr. Sanjeev mentioned, that there are about 80,000 to 1 lakh hospitals in the country. And if we are to reach all of these hospitals in the till the time we reach them, and only about 26,000, which is hardly about 25,000 of these hospitals, right? 25% of these hospitals, we still have 75% more hospitals to be connected with, and somehow start them, nudge them, motivate them to join the quality journey. And then as part of the quality journey, they should also imbibe, despite all challenges, the the nitty-gritty of the standardization, the best practices of antibiotic management, the antibiotic stewardship control, and antimicrobial resistance measures, and all those drills besides other things which have to be taken. So still, I would say it's a very long journey. Coming to the technology challenge, we today have three offerings. I think we are, I believe, and probably I'm right, that we are the only accreditation body in the world to have a end-to-end strategy for engaging with hospitals. Not only we have today the accreditation standards, we also have the digital health standards which demystify digital health. But as a third offering, we also have accreditation standards for software products in the form of standardizations for HIS and EMR products. So when together we see this, ultimately digital health is the biggest tool which is going to bring clarity, or which is going to bring make sense to the data which we collect, because the data sanity is the primary requirement for making sense of the data. We all spoke about making benchmarks for the nation. There's a lack of benchmarks, but these benchmarks require that data should be clean, the data should be flowing into the system in a closed manner, and also that this data must be ready for apple versus apple comparison. So there should be no fudging, clean and properly curated data. So for that, we need software into the system which speaks to each other, and probably which requires that technology. So this is the uh, power of that standardization, should they choose to accept. And I'll be very privileged to inform you that more than 70 top companies of the nation, they have already enrolled into this system, and 15 have already been certified, and each of these 15 is a leader which is catering to probably tens and hundreds currently of the hospitals. And a day will come when all data will be a structured data, and that day we'll be able to make sense of the parameters, the key performance indicators which can come into us. So what are the 3-4 main challenges for the technology? First, as Dr. Sanjeev very rightly pointed out, the demigods, the clinicians often feel overwhelmed by the digital tools, and they are not aligned with the workflow, and they put the maximum resistance, like user acceptance and capacity building needs to be done at a grassroots level. Probably when I say grassroots, I mean the clinicians, the actual people who see patients. They have to be well versed with the tools, because as he rightly pointed out, we are as good as or as effective as the tools, the usage of the tools which are there. There's no dearth of tools, but the clinicians, the doctors, the nurses, and probably everyone else in the ecosystem should be keen enough to use these things. The second part is the interoperability and standardization, where NABH has stepped in. And for past 2 years now, we have been helping overcome this huge challenge of bringing a standardization to this very gray industry. This is new muscle we have built. We had to go back to the drawing board, learn, relearn, and probably we are a little wiser now. Of course, we have been the framework is all supported by ABDM, the Ayushman Bharat Digital Mission, and all the latest software tools, the VASA certification, the security measures, and the interoperability and the DPDP Act, they all have been incorporated. And the third biggest challenge and the opportunity thereof is the balancing innovation, ethics, and safety. So there are many unanswered questions as far as technology is concerned, which is still a gray. Who gets to use the data? What about the data sovereignty? How the data will be used or misused? I mean, there are, it's a huge question marks. So going forward, probably we'll have to address that. And probably with more such interactions, brainstorming, and suggestions, I think the day is not far when we can start to bring out white papers. Actually, there's lots of discussion going on, and probably sooner rather than later, I'm very optimistic we shall find solutions and maybe suggestions for that. So do write in to us in case you have suggestions, you have any guidance for us, please do write to us. So I'll take a pause now.
Very much. In
Thank
fact,
you.
you have, I can see, the role of NABH now. I think 70 companies which you mentioned. I think that is a big, jump, I would say, with these technologies coming into the forefront and joining the patient safety journey. So I think that's why I'm saying NABH, I think, has gone manifold now in all the area. That is a really big work.
One more update, sir. Sorry, one more quick update is that first we opened the digital health program only for the bigger hospitals, only the accredited hospitals, and we could very soon do about 600 hospitals under the digital health program. And then we decided that let's open it for smaller tier 2, tier 3 hospitals also under the entry level program. And we were not very hopeful that they would join, because many of these are pen and paper hospitals which still stick to manual registration, ID, etc. But we were surprised when 720 plus hospitals as on date, within 3 months they joined in, and they are also keen to invest. So I think this is the new UPI of the nation, sir. Like UPI told us about financial transactions, and probably billions of transactions are happening real day from 1 rupee to lakhs of rupees with ease which no country has seen. I think this is the framework which is inviting smaller and bigger. And once they digitize and digitalize, then probably the transparency will start to flow in, transparency of billing, transparency of outcomes. I think that is, the day is not too far. Once they have basic to advanced technology in place, they will start utilizing everything. And probably riding that wave, the others can also ride in. Thank you so much.
I will have one more question from you. Hold on, because I can see the power of NABH, and I think power of Atul Mohan Kochar really is making a huge impact. Good.
All your efforts, sir. All your efforts and foresight.
I will give credit to you as well. Okay, now I have got 10 minutes for Dr. Jennifer. Because I think everybody is talking of the artificial intelligence and how it is going to make impact in predictive analytics. I think that is a key word I want to ask you. And then as extension, you tell us about the clinical decision support system. So you have got precisely 10 minutes. Over to Dr. Benjamin.
Okay. Thank you, sir. I mean, it's a very loaded question for 10 minutes, to be honest. But so thank you so much for having us. And it's again a huge honor for me to be in the midst of such big personalities in healthcare. While I did my training, I'm just going to take the question in two parts. First, let me actually do CDS first and then come to the predictive analysis and AI part. But while I did my training and I did my undergrad in US, I did come back to India right before COVID. And so I was able to see in, how healthcare moved rapidly while I was in the West, or even if I came back to India. So along the way, what we notice is these are the checkpoints, or these are the areas where we are making huge decisions in a patient care, all the way from initial diagnosis up to the time they go post discharge and home care as well. And the first half, the first page section, is where clinicians are making huge decisions, and which carries a huge point of risk if there were errors made. And that comes in especially when, let's say, it's a clinician or it is a student in training, and they don't have, and they're not familiar with what they're facing or they're treating. And then they turn towards information which can be either outdated, or they go to unreliable resources. So this is where clinical decision support is coming in. This is a technology which is giving you evidence-based, but clinician-authored resources, and it is serving as your trusted resource. It can be across roles. It's not only for doctors, it's nurses, pharmacists, whoever is involved in patient care. Now, why do you say, or why is it being improved? Why it even improves care decisions? I can just tell random things, but this is actually an academic studies which were conducted on CDS solutions, which is telling us that at least 15 to 20 questions, any clinician who goes and treats patients in a day, at least 15 to 20 questions they come across, and 60% of them goes unanswered because either they don't have the time or the resource to go to and find it faster. So when they started using CDSs, now out of the 15 to 20, they are able to find answers faster, and 5 to 8 decisions are being changed because they are using a trustworthy resource. Now, this is leading to even better patient outcomes. And the benefits of CDSs, of course, they're hugely powerful, only based on the fact that the solution is giving you evidence-based guidance, and it is at the point of care, which is helping you make even accurate decisions the first time itself. It's giving you access to the latest research and expert recommendations. Easy to use. The technology is now applicable either on web pages in your laptops or on your mobile devices by downloading applications, or even easily integratable into a clinician's workflow within EMR systems. And this is helping you to ensure that the system or the solution is easily accessible across any role, right? So the same, the doctors, the nurses, and the pharmacist. But then the question arises, wait, does that mean I need to have only the EMR? Does it work only with EMR? No, it is still accessible on your phones, wherever you want to use it. It is not replacing clinicians. We always have this question when it comes to technology and AI. Is it going to replace clinicians? Is it going to replace the decision making? No. At some point of time, we need to acknowledge that technology is just here to make our lives a little bit easier, taking away the the mundane administrative task and just streamlining operations for us. So here, in case of CDS, it's giving you a supporting, reliable resource, and for all of the roles like I mentioned previously. And while we are implementing any solutions, we did hear from Sanjeev sir and Atul sir, where solutions are coming out of the Vasu from everywhere right now. And we try to create our own solutions also. I mean, India is such a smart, such a startup hub right now. But how do you ensure that any solution, even CDSs or any solution, I think this applies to technology as well. How do you ensure that it is actually of the right quality? Because not everything is made equal. If it comes to CDSs, you need to have a review of who is actually writing it. You need to have visibility of the credibility of those authors and the content that's being written. And when it comes to adoption rate, the same thing which Sanjeev sir mentioned before. You can bring anything into your institution, but is it actually being used or not? That is a question which gives you the answer to, is it actually worth the money you've spent? Next, you just go ask your actual clinical team in your hospital, what do you actually want to use in terms of CDSs? Go ask them directly, okay, does CDSs help? Which actual CDSs is going to benefit you? And the vendors, even if it is Wolters Kluwer, I represent Wolters Kluwer, but even if it's Wolters Kluwer or any other vendor who comes to you, you ask us, whatever solution we are offering, give us the academic studies which is actually correlating impact in the real world. And at the end of the day, when it comes to CDSs, anything which is of low quality, it is just going to show you inconsistent information, conflicting information, which is further causing confusion. So in summary, CDSs is here to provide you with evidence-based up-to-date information, and at the end of the day, improve care quality and reduce cost by supporting these decisions in the first place. And it is also going to include resources such as clinical guidelines, patient education materials, and easily accessible in different platforms. So this is where I want to introduce our CDS solution from Wolters Kluwer called UpToDate. It's been there for 30 years, and we hope to be there with you guys for the rest of our life in this planet. But backed by 7,600 collaborators from across the world, these are the expert physicians who are actually focused on improving patient outcomes as well. And we have 100+ independent academic studies, which is now focused, and it showcases the impact we have in care as well as in hospital performance. And when it comes to India, as a customer success specialist, I can attest to this fact. India alone has used UpToDate last year 10.7 million times, and at least 96% of these clinicians have told us that UpToDate is their go-to resource for point-of-care decisions. 94% they agree that UpToDate improves the quality, and 99% of course agrees it saves them time. And now we have been talking about the different accreditation bodies who have taken it upon themselves to be, the quality checks and, bring in that culture in the country. So when it comes to those bodies, we took in a little bit more time to figure out these parameters and the chapters in these NABH guidelines, for example. We noticed that UpToDate itself qualifies, for example, if I stick with NABH, 35% of those parameters and those guidelines, UpToDate maps to all of them. Let it be core, let it be excellence or achievement. We are there with you in this journey. So if you are there trying to either renew your NABH's accreditation or you're doing it for the first time, UpToDate is here to support. And the same I have done in my role when hospitals were implementing digital standards from NABH. I had supported them in integrating UpToDate easily into their EMR systems based on the requirements, which would help them to further go on and get their accreditations successfully done. When it comes to return on investment, I think the same 100 studies when I was talking about, there were clear indications showcasing that UpToDate is leading in terms of supporting reduction in diagnosis drug errors, reducing unnecessary testing, lowering the length of stay, and saving time. But direct clinician feedbacks is also telling us that at least 37% of these decisions are being changed just by referring to UpToDate. And the financial benefits. So if you choose to take in with UpToDate, considering all of these financial benefits, at the end of the day, there is a typical return on investment within a year. What we try to tell is UpToDate eventually ends up paying for itself. Now, the only reason why UpToDate is so trustworthy, I have to give the credit to the editorial team who has been there. 7,600 authors growing, and we synthesize information from more than 5 lakh literature links. And they are also adding in their recommendations from these teams, which are from, again, covering 25 specialties and broad. We are very transparent about who is authoring this. Unlike other solutions, we give clear visibility of who is authoring, what is their credibility, what is their credentials. And once we have published something, we still go back to review it and update the content as and when any literature is reviewed. So the editorial process is such a rigorous process, which ends up giving you more trusted content at the end of the day. So as of today, we stand at 25 specialties covering 13,000 topics. We have 7,600 collaborators, and it's being used by more than 3 million clinicians worldwide. And in the last 1 year alone across the globe, we had 730 million content views, which is at least 28 searches every second of the last 1 year. And we realized, of course, when it came to UpToDate as a CDSS solutions, I mean, these are just, I wanted to showcase, the direct feedbacks from few clinicians from our country itself in how they showcased or how they are using UpToDate in their point of care solutions. Now, when it came to CDSs or the future or AI, wherever we want to go forward in the future when it comes to technology, CDSs, while it's been so long focused on the end user or the care teams, we were always, our information was, of course, beneficial at the point of care. But the same data, we realized it can be utilized at an enterprise level for an institution. So what I mean by that is this, how the end users are searching for UpToDate, or what are they searching for in their roles, in their departments. Or if you take, for example, the case which Dr. Sanjeev sir was talking about his wife in the beginning. If you see those random searches from physicians or clinicians in your institutions, you have direct visibility to that kind of a portal from us going forward through this new enterprise edition upgrade that we are offering. And this gives you a quick, you place in action where you can look at information, what your end users are searching for in real time, and probably keep in place safety measures, or you can probably put in training modules and seminars based on what is lacking in terms of knowledge from these roles or from these specialities. And in terms of technology, of course, we are progressing towards implementing AI in a safer and responsible way. So we also want to ensure that the accessibility of UpToDate is much more easier through single sign-on, which is what you would see it here as modern access. But when it comes to AI, I think this is where I wanted to show. We took a very safe approach because, like I showed before, this is 3 million clinicians we are influencing with our platform. And our clinical stakes were much higher. If we just try to push in something, just because it's a technology and it's available, we are causing much more harm. So what we did, we created a very safe lab environment where we invited in hospital systems, clinicians to come and test out our generative AI solution in our CDSs. We also pushed out something which is called AI enhanced search. What we try to do is going forward from November, hopefully across the world, instead of a traditional search, our AI system is now going to point you towards the topics you need to look at, which is verbatim passage snapshots. And it's just going to, again, shave away that extra time you're spending to look for information within our solutions. But we are also taking huge responsibility and partnering with tech giants like Microsoft and AHPI, where we want to bring in the predictive analysis part. We want to partner along with them in creating an integrated workflow at point of care, where our content is still the core of providing you with evidence-based information, which is what we have also done in our generative AI solution, which was more publicly announced in September last month. So it's now called UpToDate Expert AI, which is our own homegrown expert solution, but grounded within UpToDate. So I think what I wanted to showcase is when it comes to AI or any technology, I mean, NABH or all of our accrediting quality bodies in our country have taken such a huge role. And I've seen that firsthand, even though I've been in Wolters Kluwer for the last 2 years, the last 1 year, this year alone, I could see in my current role as customer success specialist, how fast institutions, even as old as Breach Candy, was trying to implement EMR solutions and trying to stick to NABH guidelines and then bringing in, CDSS solutions into it to keep it within the workflow. So we are moving towards a very digitalized country and trying to keep up with the, evolution of technology. But I think, like Atul sir was also telling, we need to be very careful about how we want to implement things, because at the end of the day, we are a little bit, lacking in being very responsible in terms of patient data. For example, if you take residents, they might just type in the whole information of a patient into a ChatGPT resource, and they're not really well aware of how they might be breaching patient's privacy and patient's data. So we are very well vulnerable to data attacks as well. And so there's a lot of things to be very well aware before we jump on the ship and then just, go on AI. So in healthcare, I think very safe approach, yes.
Thank you. I think you have covered very, very well. I will now only 4 minutes left. I'll ask one question. To Benjamin, no question, but I will give you a small task.
Okay.
One, that CDS is such a wonderful, I think, tool. Why it is still not being widespread used in India? You have to do the study and come back to me, number one. Number two, this mapping, what you mentioned, 35% of NABH and 70% of I think there is something wrong. Both these standards are based on the ISQA core standards, okay? So there cannot be any such a big difference. I think you please re-study that NABH all process and standard. I am sure, it should be covering more of that. So these two tasks for you, no question, wonderful presentation. One difficult question from my two panelists. For Sanjeev, which clinical workflow benefit most from technology integration for patient safety? So it is a difficult question. Which clinical workflow benefit most from technology integration for patient safety? Just in 2 minutes, you have to answer.
So, unfortunately, you asked Jennifer to regroup CDSS, otherwise that CDSS may help. But if I would like to be very, very specific, I think anything which is chronic in nature, like diabetes, like hypertension, like epilepsy, like stroke, a digitalization and their monitoring would be very, very critical. Just like diabetes, you sort of, because unfortunately it is point of care testing, which goes undocumented, uncalibrated equipment. So here, but then you need to also watch their fluctuations at home and at various activity. So continuous glucose monitoring and relevant information keep coming in back to the clinician. So if there is a mechanism and a consumer engagement which is being developed where the patient benefits because he doesn't have to come in on a hyperglycemic or a ketoacidosis or a hypoglycemic event, and the clinician is in always in touch so that the patient outcome is better. So one of these thing would be extremely useful.
Okay. And to Dr. Kochar, one simple question is, what impact do you foresee from the EMR rating framework on hospital competitiveness? And what should be the next step?
So thank you so much for asking that, sir. Essentially, EMR is going to churn out the objective key performance indicators about the outcome measurements which we are speaking about. It'll give the teeth to the prem and the prom which are already there. So today there's a actual vacuum as far as the outcome data is available in the market. So patients or potential patients have no way to have any objective criteria on which to base their decision of choosing a hospital, a specialty, or a doctor to say. And if we have this objective EMR, that is going to churn out, and that is going to be the basis, the foundation, the linchpin around which the entire predictive analysis industry or even the policymakers, they are going to base their budget on. They are going to identify they are going to have prevention of future pandemics, so to say. So from maybe a possible choice of a specialty or a doctor or a procedure to the largest national level cause, I think EMR is going to be the foundation for that. It's a foundational requirement, or digitalization. So first, probably a hospital information system, HIS. Then on that, we have a layer of EMR, and the data which flows into this EMR, the granular each patient's data. Probably we can put in filters of AI or a framework and layers, and that can churn out the real concrete data on which the healthcare models, delivery models of future will be based on. So future is very bright, sir. Maybe next 10 years are going to, for Indian healthcare. I think there's no reason that Indian healthcare cannot come out at the top, not only as far as advanced procedures, but even for basic healthcare delivery for our own nation. It's a true model which is worth waiting for.
Thank you. I think to me, I will sum it up that this has been the most value-added, I think, webinar. Dr. Sanjeev and Dr. Kochar, of course, two are the names, in our country, which actually symbolizes the patient safety. And I think the way they have come out, very crisp, description of our journey in our country has been wonderful. And Dr. Jennifer, I must tell you that I have heard quite a few talks on CDR, including few from the Wolters Kluwer. I can tell you simply, you are the best out of all the talks I have heard. You have been very crisp. And I think I will tell Lakshya to use you in the future, our meetings. Very nicely done. So, Lakshya, you want to add anything? Because we will close in another minute or so. Lakshya, you have anything to add?
Sir, no, we have certain questions from the joinees as well today. So I have few questions. I'll just, in your time, I'll just ask few of them
Okay,
to the
one
speakers.
question to each of the panelists, okay?
Sure, sir. Thank you so much. So we have one question from Anchit. What are the common challenges people face when trying to bring these ideas into practice, and how can we overcome them? I think Dr. Sanjeev already covered few challenges for tech, but then, sir, if
It
you
has
want
covered 7 challenges very nicely.
yes,
Yeah.
already. So I think I'll maybe jump to the next one, which is, can you highlight 2, 3 most important steps that we should follow to improve patient safety and care quality in India? Sir, Dr. Sanjeev, if you like to maybe
I'll have
highlight or sum up which is.
Dr. Atul answer that and I'll follow.
No, thank you so much, Dr. Sanjeev. So essentially, see, I think Dr. Sanjeev only broached the topic very well in saying that punitive action has to stop. We cannot, what what's a good word? We cannot blame the pizza delivery person. We cannot shoot the messenger he mentioned, right? So patient safety is as strong as the culture. So if every institute, every facility, big or small, they imbibe that in intent, and we encourage our staff to report near misses or misses also, and then do the uh, kappa. He also had a word for that. So if we could do that in principle, in true sense, there is no reason why we cannot establish a culture. So these are very powerful frameworks, right? But any tool, any technology, any framework is as good as the people who are using it. So initially, for initial thought, it's good to be maybe investing into NABH or any accreditation for the incentive which flows in. But ultimately, you will realize the top management will realize that their staff is happier, their facility is safer, and their outcomes are better. And the moment they realize that, then they start to practice. So this lag is also understandable. But now it's been 20 years. There's no reason that smaller hospitals receive that legal teeth, that regulation, that voluntary concept has to dissipate. So we are a voluntary body. I mean, every accreditation is voluntary. One more thing, if just 30 seconds I'll take. And in the garb of accreditation, many third parties are entering the country, and they have no skin in the game. They only wish to take the money and give that certificate, and from one room they are operating 40 schemes. So and this is something like a sucker is born every day. I mean, people are gullible, or whatever hospitals need, whatever their inferiority complexes are, maybe they need to put in those golden seals, etc. So those things are also a danger to the nation. See a foreign body coming and giving a printed certificate which is not worth the paper it is printed on. That is also something to be very wary of. Or probably that's matter for another webinar. But we must all undertake, maybe pledge, that if we are serious about patient safety, healthcare quality, we must invest in it with the letter and spirit.
Okay, Dr. Sanjeev, you want to add anything?
No, just a bit, sir. There is lot of raw data in all hospital. Huge. Unfortunately, they are only busy collecting raw data. That has to, the call for action or a data for action is important, and I think that should be stressed. Other than the points which Dr. Atul mentioned.
Okay. Any one last question, Lakshya, you have?
Yes, sir. One interesting question. I'll just sum up with this one, which is how is the rise of platforms like ChatGPT among new doctors influencing the adoption and trust in clinically validated CDSS tools, and how reliable are these AI solutions when you compare it with others?
Sanjeev or Jennifer, one of you can.
Yeah, so we have tested this. We are doing this study, and I don't know whether you would like to hear this. It is 85% verified. It is giving right answers. And if you link it, it is all the probable or a possible diagnostic or suggestions are pretty good as of now. I am sure it is going to go better. But even ChatGPT has started using a tagline, not a tagline, a disclaimer that ChatGPT can make mistakes. So let's also use that and keep that in mind.
Okay.
Even the recent changes in the Google search platform, they have truncated after 10 readings.
Yeah.
That is going to hugely affect the output of the chat GPT and other search engines. So that also is so currently they are there. 85% is being very generous. They are very, so there's a huge method to that, but probably will need investment. So
Right.
that's the future actually.
Okay, I think
Dr.
with that,
Jennifer?
I think we will like to close, I suppose, and
Yes, sir.
open VOH.
So,
Okay, you can close, yeah.
sure. Uh, on the last question, just sir, if Dr. Jennifer want to add something on the AI bit and ChatGPT, we also had a study there. So
So I think more than a study, it was actually a direct testimonial from Dr. Shashank Joshi. We had participated in GDS's summit. If VOH can help me, I'm unable to share sound again from my side. I wanted to share his testimonial. It was actually just a minute long. But if VOH can enable my sound sharing, that would be helpful. But yeah, so he was just sharing his personal experience as well, where it is still, what content are you actually reading? Yes, the solution maybe from ChatGPT, what you're reading might be great. It might look very reliable, but is it actually verifiable? Who is verifying the content? The technology is reading and summarizing information for you. It is not the human who is doing it, who is actually trained in it, and who is actually, trained in evaluating evidences. Let me just see if they're, yes, great. So let me just do, nope.
Are you able to do it right now?
I'm unable to do that.
Now check. I think now you will be.
Maybe a systematic review would have been better since we are
Yeah, it's all a subjective.
pyramid,
I
pyramid.
understand what you are saying. You already made your point.
Yeah.
So let me just see.
Yeah, so I have been an up-to-date user, from last 25 years. It is very difficult for a Gemini or a AI tool to replace it for two reasons. Up-to-date is validated and vetted by domain experts in that area, while the Gemini is not vetted by anything. So I am not sure what information is coming out is garbage. Is it really vetted? Is there appropriate reference? There is no background check on it at all. And I think that is the human element which I'm talking about, that if you don't have a group of experts filtering out that information, you will have a disaster. And up-to-date one went two steps further. They went and generated their own analytics and their own outcomes, doing some science and data. So the biggest problem with AI is AI needs to generate its own evidence base in the way we look at evidence-based medicine, and not just some, output. Information sieving is an art. And I think UpToDate was one of the first ones to do that correctly and appropriately. That's my take on it. Sorry for the interruption.
Excellent.
Okay, I think with that, I think that is okay. I think I don't want to get into this debate. We know about utility. So thank you very much. Wonderful webinar. And thanks to Wolters Kluwer, thanks to VOH, and of course, big thanks to my three panelists, Dr. Sanjeev, Dr. Atul Mohan Kochar, and Dr. Jennifer. Thank you very much.
Thank you so much,
Thank you
sir.
so
And
much.
a big thank you to our audience as well for the active
Definitely.
participation and questions. Before you leave, we kindly request all the audience to just take a 2-minute survey. This will really help us to improve our sessions in future. Thank you, everyone, and thank you all the eminent speakers. It was a pleasure.